So when we had stopped last time, we had been on this slide and we were talking about how overall at the proximal near end of the capillary bed, the overall movement of fluid is out. Because when you add up the force of the hydrostatic pressure and the force of the osmotic pressure, the overall direction of fluid movement is out. At the distal end, or the far end of the capillary bed, we've got some hydrostatic pressure pointing outward. We've still got osmotic pressure pulling in, and normally the overall movement is fluid coming in. So fluid going out at the beginning, fluid coming back in at the end. But we have lost some fluid that's not been recaptured from the beginning to the end. And the hydrostatic pressure has gone down from beginning to end. So what that ends up meaning is that all over the body, as you move from the aorta through large, small arteries, arterioles, capillaries, by the time you come out of the capillary bed, the hydrostatic pressure is pretty low. So they're calling this systemic blood pressure. That is like what we think of as hydrostatic pressure. And the blood pressure drops pretty drastically, and by the time you leave the capillaries, the pressure of that fluid is kind of low. But it still has to make its way back to the heart so that it can be pumped out all over again. Remember, this is the systemic or the pulmonary circulation as well. So veins have to be bringing blood back to the heart when it's at low pressure. They've got to have strategies or structures to help them do that. This is a list that you should memorize. So remember, last test, there were 3 steps to hemostasis. And I said, you need to know these, and you might have to write them on the test. This is a similar kind of list. What are the mechanisms that veins use to help blood move back to the heart or uphill when it's at low pressure? And they have 4 ways to do this. Number 1, they have big lumens, large lumens. So let's not, in veins, let's make it easy for blood to move back up to the heart. So they have big lumens. That's also how you recognize them on a microscope slide. That's pretty easy to understand. The second one is that your veins, and especially your bigger veins, especially the bigger veins that are returning to your heart, they have one-way valves of their own. So if we could just get in this vein, if it's moving upward toward the heart, if we could get blood past this point, the valves will keep it there and not let it go backward. So you have venous valves in your bigger veins. And they generally work like heart valves, but they're not as strong. Same concept. The third concept is really cool, and it has to do with just your muscles contracting as you walk, or as you flex your leg on the airplane, or as you just generally move around. Your muscles are squeezing on the veins as they contract and relax, and that squeezing pushes blood up past a valve, and then once it's past a valve, it won't go back down. So that's the muscular, it's called the muscular pump. It's not separate muscles, it's your normal muscles just doing their thing, contracting, and the contracting squishes on the blood, pushes it past the valve, and we've moved it upward. Cool, easy to understand. This also has to do with that deep vein thrombosis. You're not getting blood moving because you're not moving your legs and you're just sitting there. So in those cases where you're being sedentary, or if you're bedridden, or if you're just on the couch too much, you're not getting muscular pump to help your veins move blood back. And then you might get higher risk of blood clots or thrombus there. The fourth mechanism is harder to understand, but is even more cool to me. And that is when you breathe, you're helping suck blood up toward the level of your heart. That's called respiratory pump. So I'll let you write those words. It's respiratory pump lowers the pressure in your chest cavity. If you ever watch these videos and you can't see the words, you can email me or you can ask your friend in class. Couldn't see the words. It's still better than nothing. But the words are respiratory pump and it lowers the pressure. So when you breathe, and this is going to be on the next exam, when you breathe, you contract your diaphragm, which normally sits like here, and it moves down. And when it moves down, you've got more space in here. When you've got more space with the same amount of gas, that gas is under lower pressure. So when your diaphragm moves down, your chest cavity is at lower pressure. That's going to make air rush into your lungs, which is good. It also makes blood get sucked up a little bit into the vena cava, just because this whole area is at low pressure. So it sucks air in, it also sucks venous blood up, which is cool. Just by breathing, you're helping your blood return up to your heart. So this one works as long as you're breathing, whether you're lying down, standing up, headstand, flipping in the air. Respiratory pump helps you as well. So all of that together, you're sucking up blood upward toward your heart because your chest cavity is becoming at low pressure. You are squeezing blood up if you're contracting your muscles. That's muscular pump. You have valves to help you. So once blood has gotten past the valve, it'll stay at least to that level while these other mechanisms help. And the veins themselves have big diameters or big lumens so that that's not a barrier. Those are the 4 ways. That's a list you should memorize. What are the 4 ways that veins help move blood back to the heart? We're actually not going to watch the video about varicose veins. That's not a life-threatening thing. It's an interesting video. But what happens when people have varicose veins, the valves blow out. It's a blown valve in your veins. So imagine you blew, let's say it's this one. This valve doesn't work anymore. So it's harder to get blood up to that level, and you get more blood accumulating at this level, and that might make the vein bulge out, and we call that varicose veins. In some ways, varicose veins are a cosmetic, oh, it's ugly. If they get really bad, the people will have somewhat worse blood return to the heart, and that's when it becomes a problem. Normally it's a cosmetic thing. And I had a friend that was so fit and like ran all the time, and she had the worst varicose veins. It doesn't always mean that the person is sedentary. It just has weak venous valves. That's how they happen. I want to go on to the next slide set now, which is just called blood pressure. And blood pressure relates to the heart function. It relates to blood vessel structure. It relates to what capillaries and veins are doing, but it is a big, important, it's one of your big vital signs. Like, what's your blood pressure? Is it good? Is it bad? How can you fix it? So this is one of the big topics on your exam on Friday, is things related to blood pressure. Blood pressure is really generated by the left ventricle. I mean, you can think of it as it's highest at the aorta because that's closest to the left ventricle. But we should add that on. Is generated by the left ventricle because that's what's pumping blood to the systemic circulation. Right after blood leaves the left ventricle and it's going through the aorta, the aorta is the place where your blood pressure is the highest. Absolutely the highest. And then it drops as the blood moves through the body, and it's lowest. Where would it be the lowest? Right before it comes back into the heart. So there's a picture, this picture. It's highest right after the left ventricle pumps blood. It's lowest right before it comes back into the heart. So there's quite a drop in blood pressure as blood is moving through the systemic circuit. We measure two different kinds of blood pressure, and I know all of you have had your blood pressure measured sometime. You may have learned that your blood pressure has something over something. There's a top number and a bottom number. We call that systolic and diastolic. And that's referring to what did the left ventricle just do. We'll come back to that in a minute. This is a picture of what we call pulse points. So if you're going to take someone's pulse, what a pulse is just a pattern of blood pressure surges. So when you take someone's pulse, you are feeling the difference between the pressure of left ventricle contracting versus the in-between. So these are places where you technically could measure blood pressure on someone. We generally do up on the upper arm, but you could also call these pulse points. You feel your pulse in these places. If you go into nursing, you probably have to figure out how to take a pulse at any of these places. When people are stressed, and you can see that, we say, I see a vein popping out of their head. Well, really what it is, it's their temporal artery. That would be a good poker tell if it gets to that level. But when we measure the pulse, we're measuring differences between the systolic and the diastolic. The systolic is that push of blood that's generated by the left ventricle squeezing. And when it squeezes, it puts all of that blood under hydrostatic pressure. And we feel that or measure it as the systolic pressure. It's not like our blood pressure goes to zero in between heartbeats. There's still pressure in there. That residual pressure, oops, I forgot these words. Hold that thought. So still with systolic. Systolic is transient. That's a good word. Comes and goes. Transient pressure. And it's going to be the higher number. So it's going to be bigger in value. It's going to be the top number of our two blood pressure values. That's systolic. And it's generated by the left ventricle. So when we, in between heartbeats, our blood pressure doesn't go to zero. There's still pressure in the system in between left ventricle contraction. And we call that residual pressure, or the constant number, that's the diastolic pressure. Diastolic. How many of you already knew this systolic, diastolic pressure thing? Like, I didn't know it was called that before A&P2. How'd you know that? Because you've already had exercise days, right? Or maybe some other class. Yeah. Yeah. There are special populations that have blood pressure that's too high, blood pressure that's too low. Then you have to be careful about their exercise. But the diastolic pressure is the bottom number. So systolic is the top number, diastolic is the bottom. You may sometimes hear people say that it's that bottom number that's more important. The bottom number is the constant pressure through all of your arteries, veins, all the time, your whole life.
It's
The
not
residual
really
pressure.
constant, though.
It's not, you're right, you're right that it's not totally constant. Like next week it might be lower than this week. But if you're, let me go on to this next slide. It's not totally constant. You're right that it falls throughout the body. But that if you add up all the pressure on your arteries and veins over time, most of it is coming from the diastolic as the bulk of it. I shouldn't say that it's a constant pressure. It is a more frequent pressure. Okay, go back and change it. More frequent pressure. More frequent. Constant is overstated. It's more frequent. More frequent. So, on your arterial system, you can see once we get to past the capillaries, there's no difference in systolic, diastolic once you are down in the vein system. But in the arterial system, there's a gap between those two, and the smaller the artery, the more the gap narrows. But the systolic is the higher. The systolic is the higher. So in the artery network, the diastolic pressure truly is the more constant, and you can think of it as that's what your arteries are putting up with all the time, with surges of systolic in between. I don't talk about how to measure it in here. You might be doing that in lab. It's a lab thing. What I talk about in here is what affects it. What are things that affect blood pressure? And when I think about blood pressure, what makes sense to me is to compare the heart to a pump and the blood to tubes, the blood to water and the blood vessels to tubes. That helps me think about it. If that system doesn't help you think about it, you don't have to put your mind in that direction. But that helps me think about, we've got a pump, we've got fluid, we've got tubes that the fluid is moving through. Should have put that up already. Okay. So, if I relate blood pressure to those factors, the strength of the pump is going to affect the pressure of the fluid. So if your heart is pumping harder, your blood pressure is going to be higher. That kind of makes sense. If your heart is pumping with less force, your blood pressure is going to be lower. When do we measure people's blood pressure? Usually.
At rest.
At rest. At rest. So if you have high blood pressure at rest, you're going to have really high blood pressure when you are exercising. If you have high blood pressure to start with, it's going to be maybe dangerously high if you are exercising too much. So just keep that in mind. When we talk about blood pressure numbers, they are going to be at rest. But if your heart is working harder, you're going to have higher blood pressure. The second factor is the resistance, and this is a more difficult concept. Resistance is like, let's talk about the hoses or the tubes. So the more tubes, either the length of the tubes or more tubes in general need more pressure to move blood through. So this is like, if I think about fire hydrant, sorry. A fire hydrant. Fire hydrant has to be under very high pressure because the point is to get water through the air onto a structure through one of those big hoses. So if we have a long length of hose, we need more pressure to get water through that hose. This means that people that have more blood vessel length, for some reason, their heart is going to have to pump harder to get blood all the way through. I'll come back to that topic in a minute. If the tubes are narrow, or let's say if the tubes are narrower, that's going to increase pressure in the system. Does that make sense? If the tube is narrower and you've got the same amount of liquid in there, it's going to be under higher pressure. Like if you tried to hook up a little straw to the fire hydrant, that's silly. It would probably explode. It's under too much pressure. But the narrower the tubes, the higher the pressure.
Is that why it's different for like your height and weight?
This is coming back to why it's different for your height and weight. Who should have higher blood pressure, a big person or a little person? A big person, I mean, if their general health was the equivalent, because the big person has more blood vessels length through their body. This also comes back to obesity. Like the more of you there is, the more blood vessels you have to supply all that. That relates to why obesity tends to raise blood pressure. These two things also matter. So this is about the fluid itself. Number 3 is just how much blood do you have? Like we could say that, well, how much blood is there really? What is the blood volume? If you've got more blood in the same system, it's going to be under higher pressure. The fourth one doesn't come up that often. Like our blood viscosity doesn't change that much, really, unless you are EPO doping and you've got more red cells than your average person, then this becomes a problem. But in your average person, the viscosity doesn't change much. The volume can change. The strength of your heart can change. The length may change slowly as you grow or get fatter. This changes pretty frequently. Your nervous system can change your diameter pretty frequently. So all of those things together will affect your blood pressure. We can talk about two different problems of blood pressure: hypertension, hypotension. If we are outside of a hospital setting, it's usually hypertension that we worry about more. For your average person in a non-emergency situation, hypertension tends to be more of a concern. And what we consider hypertensive changes every 3 years, it feels like. I haven't even updated this since the summer when the whatever governing body said, oh, I think that we ought to change what's hypertension again to these new, more strict values. So if you're going into nursing or exercise phys, like I don't ask this on a test because it keeps changing, and you're going to learn a new number when you get into nursing or exercise phys. So generally, if diastolic is over 80, that's kind of a concern. If systolic is constantly over 120, that's kind of a concern. These numbers go down over time. But say if you have a patient and their diastolic is 110, that's a problem. That's a problem. If their systolic is up at 150, that's a problem. And so the higher it is, the more dire that situation. Hypertension doesn't cause you an immediate problem. We say it's a silent killer. What's wrong with having slightly elevated blood pressure? So what? Just makes you more alert, right?
It puts your body under more stress.
It puts your blood vessels and your heart under more stress. That's what the problem is. So it's a long-term, a problem that will, the longer it goes, the more damage. But for several years, it's not going to do anything to you immediately. I have hypertension. I got a top number under 100 a couple months ago. I was so excited. It was a Walmart blood pressure machine, but still, I was excited. So I have a lot of hypertensive risk factors we'll talk about in a minute. You don't, if you have it, you don't really feel it, usually. It's not something that you notice, but it's the long-term damage that can damage heart, blood vessels, kidneys, several different organs actually. So one reason why hypertension tends to be more of a problem is that the opposite, hypotension, so too low of a blood pressure, that can be a real immediate threat to our body. If we're not moving, if we don't have enough pressure in the system to move blood throughout the whole body, that's an immediate problem. That means that some part of our body is not getting nutrients, gas exchange, waste removed. We must have blood going to all parts of our body. So we have, and if that didn't happen, really low blood pressure, like if you completely lose pressure, especially in the arterial system, if we got down too low in this system, we're not supplying blood to all the body, and we call that circulatory shock. I'll go back to there. So we don't want to be in circulatory shock. That's not a silent killer, that's an immediate death type of killer. So our body has a lot of ways to raise our blood pressure just so that we don't go into circulatory shock. We have a lot of safeguards like, oh, okay, let's have 4 ways to increase blood pressure. And we don't have that many ways to decrease blood pressure. So that's one reason why hypertension tends to be more common. So if our body needs to increase blood pressure, we can have more blood volume, which we do by retaining water. So we could do this one by retaining water or sodium. That's going to come up later. We could retain water and or sodium. That will increase our blood volume. That will raise our blood pressure. We could increase heart rate. How could this happen for us? Do we have to look at our Fitbit and say, oh, my heart rate is low, and then start moving? Your autonomic nervous system does this for you. You can get sympathetic nervous system activation really without realizing it to raise your blood pressure if you need it. Our heart can beat harder. Sympathetic nervous system would do that as well. So this is your heart contraction strength goes up. Any of those things can cause your blood pressure to temporarily increase, and your body has multiple ways to enact that for you. These are short-term. I might want to write that up here. These are short-term things. So if you have an immediate problem with hypotension, your body will start trying to do this for you. These things do not change, like these aren't going to change in the next 5 minutes. These are longer-term changes that can affect blood pressure, but they're not going to fix anything in the moment. What is this peripheral resistance? What does that mean? I don't think I used that term yet.
You're talking about like.
It's just the flowing
Flowing?
of the blood.
It is the flowing of the blood past peripheral resistance, which is blood vessel length. This is where the blood vessel length and diameter comes into it. I don't know why it can't be called blood vessel length and diameter. It's called peripheral resistance, but that's what it means. So your blood vessel length and your blood vessel, actually the diameter can change short-term or long-term. But the length is not going to change too quickly. How's this seem so far? A lot of things can change your blood pressure. This handout that I gave you, you're going to have, it's kind of a practice handout. We'll go through some of these in class as we have time. You're going to have questions like this on your lecture exam. So I want to talk about that for a minute. So up at the top it says, how is blood pressure affected by dietary sodium? And I'm talking about, like, does it go up? Does it go down? Does it stay the same? So that would be one part of that question. And you could guess, like, up or down, 50-50. Saying why, that's some other points of that question. So you'll have some of these on your exam. All of these are important. All of those are important to know for this class and beyond. Okay, hypertension and treating it. What should people do if they have hypertension? Do you know?
Eat right.
Eat right? Yeah. What is, well, eat right. Sounds so easy. Eat right how?
By lowering sodium intake?
So, lower sodium. Lower sodium. Exercise. Does that seem
Counterintuitive.
counterintuitive? Thank you. You're saying, no, does that seem all right? Counterintuitive? When you exercise, your heart gets more efficient, and it also stretches it makes your blood vessels a little more stretchy. So that's where exercise comes in. You don't want to overdo it. Like people with dangerously high hypertension should medicate first, get it down to a stable level, and then ramp up exercise more slowly. Yeah, I just left that completely blank. Possibly medication. I'm just going to write just possibly medication. I'm going to put specific ones right now, but some of those medications are diuretics that make you get rid of extra fluid, and that reduces some of the pressure on your blood vessels, is one of them. Blood thinners, maybe. Those have dangers of their own, but that can help. So I want to come back to this sodium thing. You probably heard sodium increases blood pressure. Here is how and why. And this concept of sodium and fluids and fluid balance, it comes back around 2 more times in this class at least. At least 2 more times. And this is why. I want you to memorize that water follows salt. 3 words. Water follows salt. One time several years ago, my little boy had to come to probably this same class 5 years ago. And at the end of it, I asked him what he learned. He just said, water follows salt. Like if he keeps that all the way through high school, that will really help him with life concepts. And this is why, physiologically. In your body, your sodium levels are critically important for nervous system stuff. Remember all that you gotta have sodium going out, and sometimes sodium comes back in, and it causes depolarization waves. Sodium is really critical to your body. If you hunt and you put out salt for deer, well, they're going to come to it because it's critical for life. They're coming to get salt. You have to regulate your sodium levels. I think this is the range. It's like 9 to 11 something per something. It might be milligrams per something. But that's a really tight range. Like it's got to be, it can be 9, it can be 10, or it can be 11. Beyond that, it's a problem. So your body, your body will make sure that happens. Almost all the time. You might crave salt if you, this doesn't happen. This doesn't happen in modern Western society, really, but if you've heard of people that when they're pregnant they start eating dirt in like other countries, that might be their body trying to get them sodium when they're lacking. We eat a lot of processed foods, so that doesn't happen much here. But the other way, if you have too much sodium, your body will make sure that you balance it by keeping water. So here's how our body regulates sodium. So we regulate sodium by keeping in water. Like if we have too much, it's like if you make Kool-Aid and it's too strong, you can put more water and balance it out. So we'll keep more water if we have too much sodium. Or we will excrete sodium by peeing it out. I mean, somewhat by sweating it out, but we don't unconsciously start excreting more sodium through sweat, really. But it will come out in your urine. Your kidneys will help you along there. It's usually both. So we try to get rid of extra sodium by peeing it out. If we can't pee it all out, we will also retain more water to balance out the levels, but we will do what we have to do to keep it in these levels. Here's an example. So part of the reason I was able to get my blood pressure down is because I've been eating better and not eating Fritos on the couch at night, but that's one of my comfort things. Like, you know, if it's Friday and I'm done with the week, it's like, yeah, it was a good week. I love just the regular Fritos. Just kind of be on the couch eating my Fritos. Well, what's going to happen the next morning?
You're gonna take a lot of water.
And be puffy. And I can feel it in my rings, and sometimes I could see it in my face now that I've been eating better. But you're going to retain water. So you retain water. Wrestlers know this because when you're trying to make weight, you know, you're going to pee out a lot of that weight if you're eating salt or sugar. But salt is a big one. you will keep water to balance that salt so that you're staying between 9 and 11. So if you eat Fritos on the couch, or just, like whatever processed food, you're going to puff up the next morning. It's more pronounced in women because of hormonal effects. And if you truly cut sodium, you will lose water weight because now you're getting down to your correct place. You don't have to keep more water. Probably every female has noticed that. It's not as bad in guys, but it does happen. It does happen. So, if you've got too much salt, you will keep water to balance it. Same somewhat for sugar, but salt is a more immediate effect, actually. So, if you are eating extra sodium, you are retaining more water, and you are increasing slightly how much fluid volume is in your whole body. You've got a little bit more blood. It's going through the same tubes. It will raise your blood pressure. Does that make sense? Sodium is the major mover of that, more than sugar in general. So that's why you should, cutting sodium will help with blood pressure. Now we come back to, well, okay, it's a silent killer. What does it really do? One thing it does is it causes arteriosclerosis. This is one of your vocabulary words, arteriosclerosis. That's a technical term for hardening of the arteries. So artery, stiff arteries, so that when they're under pressure, they don't flex as much as they should. So they don't flex, then they get under more pressure because they can't flex, and it becomes kind of a vicious cycle. Hardening of the arteries. That is not the same word as this next word, which is atherosclerosis. And we still got sclerosis, which is not stretchy. We're not stretching enough, too rigid. This one is from plaque. Atherosclerosis is plaque buildup, and it got cut off because of the picture. This word is plaque. When you start to have arteriosclerosis, your arteries just get generally unhealthy and they get rough surface on the inside, and then it makes it easier for plaque to build up and make it even worse. So now they're not stretchy, and they've got plaque, and they're narrowed, and they're under more pressure than usual. So usually, if you have atherosclerosis, you also have arteriosclerosis, but those are two separate things. Be watching for that. Athero, arterio, they're not the same. And both of them have the effect of causing your blood to be under even more pressure. So that's the blood vessel part. It also puts strain on your heart. So if your heart has to pump blood to all parts of the body. If your arteries are having trouble being stretchy and they're also clogged, your heart has to work harder to deal with that. And when this happens over time, we call it congestive heart failure, or CHF. CHF. It could be that your whole entire heart is failing equally on both sides. That doesn't happen very often. There's usually one side that has more trouble than the other side. If your left side of your heart is having problems, you get a backup of blood in the pulmonary circulation. And this is another thing that may seem counterintuitive. If you've got slides that you write on, get out the pictures that has the chambers of the heart. And I'm going to draw some lame pictures of them. here's right ventricle, left atrium, right atrium. If this side of the heart is messed up and it's not working well, it's just going to get better. Right lung. Okay. The blood that's trying to come in from the lungs, it's going to back up because this is not pumping blood the way that it should. We've got to back up behind there. We've got blood backing up in the lungs. Does that make sense? A better picture would make this better. But if we've got blood backing up in the lungs, that pulmonary circulation blood is under higher pressure. It's like that old clip from I Love Lucy when she and Ethel have all the chocolates coming down the line. And they're supposed to put them in a box or something. They can't keep up, so they just start shoving them in their shirt and they're piling up behind. The problem is before it gets to them, it's backing up. So if the left side fails, we get blood backed up in the pulmonary circulation. It's under pressure. We get more fluid leaking out of the blood into the lungs. We get pulmonary edema. You could relate this back to those capillary dynamic pictures. So you're getting too much fluid in your lungs. That's dangerous. You can't get oxygen and CO2 through the fluid very well. So that's going to cause blood gas problems. And this would be partly how you diagnose somebody that has left side heart failure, is that they have lung problems and they have low blood oxygen. And they will also have probably acidosis, which we'll get to later in the semester. If their right side is failing, I'll add on to this high quality picture here. If their right side is failing, we've got blood backing up in the vena cavas that is, trying to get into the heart. The right side can't keep up. You get a backup in the systemic circulation. The blood from the systemic circulation cannot be processed fast enough by the right side. You get higher pressure back there. You still get edema, but now the edema is in the systemic circulation, not in the lungs. What do these people look like, if you had to guess, or if you know somebody? What's systemic edema, general tissue edema, what would that look like? Swollen, puffy. Yeah. That's general tissue edema. That tends to be from a right side problem. There are people that have both. Well, that's just really bad. Just really bad. And if you've known people that have congestive heart failure, there are a lot of them out there. They are not really going to get better. They're not really going to get better. It's kind of a thing that you have to manage the rest of life. You hope it doesn't happen when you're young. This right side, left side thing, I'm going to ask about this on the exam as well. Like, and it could be, as simple as if someone has systemic edema, which side of their heart is undergoing more likely to have CHF and why? And why? That kind of thing. Or if someone has poor oxygen levels in their blood, are they more likely to have right side or left side heart failure, and why? So the right side, left side thing is, that's a 50-50 shot. The why is this. So, does that seem okay? This is the thing that students tend to get backward because you memorize, oh, the left side of the heart serves the systemic circulation. It's the backup that causes the problem. So those are the big problems. So hypertension causes arteriosclerosis, atherosclerosis, congestive heart failure, and then number 4 down here. It's not that these are minor, but this is a fourth thing. Kidney problems, so messing up your kidney filtration because it's just the pressure's too high. And also eye problems, which has to do with all of that fluid in the inside of your eye. It's related to this fluid, and if you get too much, it damages your retina and so on. So on. Is that the last? Yes. Jamira, if you could turn off just push that little red button.